for their license and be the best that they can be in whatever capacity that is. So Linda, thank you for joining us today. It's a pleasure to have you.
I'm glad to be with you. And there's definitely some folks on the call that I recognize from STFM as well, which is lovely to see. Today, hey, Bob, wait a minute. Today I am representing STFM, where I'm currently serving as the president. And it's pretty darn exciting as a psychologist to be president of the Society of Teachers of Family Medicine. I'm not the first non-physician to be president. There's been 5 others in the 50-year history, but very proud. And I think it, again, speaks to the interprofessional nature of the Society of Teachers of Family Medicine. My day job is the behavioral science educator at the University of North Carolina here in Chapel Hill. And there I'm responsible for our behavioral health curriculum for family medicine residents. I do some training with psychology graduate students, and then also facilitate expansion of integrated care, both within our own clinic and a couple of federally qualified health centers that are in our area. And so what's kind of interesting about this whole process with the new family medicine ACGME program requirements is that we still don't have the final rules. We thought we would. It was anticipated that the final rules would be approved by the ACGME in July. And because of some issues and things that they disagreed with, they postponed approval of all of the new program requirements until September. And it was just earlier this week that they have made their final approvals. I still do not have a draft of what that looks like, though. I have the previous drafts. And so some of the things that I wanted to bring out today are from those previous drafts. I don't anticipate that the things we're talking about today are likely to change, but there's some other things within the program requirement drafts that we saw earlier that are likely to change or not be implemented. So it'll still be interesting for all of us who teach in family medicine residency programs to really finally get our hands on what the changes are going to be, because they are going into effect next July. So it would be helpful for me just to get a sense of the audience. How many of you are teaching in family medicine residencies right now? And either just to do a quick raise your hand with the reactions, just so I have a sense. Okay. Quite a few of you. Excellent. Excellent. That's really helpful. Because one of the things that was really exciting to see in the draft program requirements is an increased emphasis on behavioral health. And this is an opportunity for us as behavioral scientists to really continue to make a strong impact. And some of the changes that we've seen are just really nice and supportive and aren't going to impact us in terms of our curriculum too much. But there's a new requirement, for example, that says specifically that program directors should integrate multiple non-physician professionals to augment education, as well as interprofessional team clinical services. And they specifically list out behavioral health as one of those. Now, those of you who've heard me speak before, you know that I don't like that non-physician language. Because I am not a non-anything. We are behavioral health professionals, but at least it now specifically requires program directors to think about integrating a variety of interprofessional team members into the educational process. So I was glad to see that kind of call in the requirements. There's some other requirements that focus specifically on the educational elements of what has to be included in the behavioral health curriculum. And there's one of the rules that really focuses on family dynamics and stage of life issues. Many of us already have these things integrated into our curriculum, but they're specifically called out now in the new standards. And I think it'll be helpful for us to take a look at those and make sure we are addressing them. And they are things like family dynamics, the impact of adverse childhood events, trauma-informed care, really understanding the allostatic load and structural determinants of health, and again, inequities in healthcare. And that's a role that many of us play in addressing in our curriculum. So those are some of the things that have specifically been called out. There's another requirement later in the standards that pulled out some specific things that also need to be included in the behavioral health curriculum. And one of the things I thought was really interesting is they say specifically CBT, and along with motivational interviewing, psychopharmacology, and substance use disorders. Under substance use disorders, they specifically list out pharmacological and non-pharmacological interventions, as well as interdisciplinary team approaches to substance use disorders. So again, you're seeing that emphasis on integrated interdisciplinary teams. But specifically to call out CBT was kind of interesting to me, because I often have residents who come to me and say, I want to learn CBT. And I say, great, I've got a graduate training program that I can send you to. What I reframe it as is I tend to teach brief CBT interventions. Okay, the basic understanding of CBT, but the brief interventions that are really applicable for a family medicine physician. They're not going to be doing true cognitive behavioral therapy, but they can learn some elements of that and really integrate that into their care. All right. There's other requirements that focus on the biopsychosocial model and collaborative care planning. And so those, again, are things that we can look at making sure are part of our behavioral health curriculum and broader beyond that. But one of the most exciting things that led to this community conversation is a new requirement that specifically says that each program should provide an experience in integrated interprofessional behavioral health care. That is new. We've had an emphasis on behavioral health education, but now this requirement is recognizing how critical integrated care is for the future of primary care. And it specifies that residents need to train in integrated care models. They need to be able to practice in those integrated care models so that then they leave our residency programs, they have the opportunity and know about a variety of different models and can continue to advocate for that going forward if they're moving into a place that doesn't have an integrated care system yet. Now, for some of us, that's just a big win because we already have integrated care happening within our clinics, which is wonderful. But for other programs, residency programs, they really don't have integrated care. And the standard doesn't really specify the degree of integration. There's a lot of variability, and we know that because it could be that the lone behavioral science faculty member in the program may be doing a little bit of co-located care, and the program may checkmark that and say, oh, see, we've got integrated care. And one of my concerns is that that would shortchange the educational experience. So we really need to get a much better understanding of, across our residency programs, what is the degree of integration? What are the models that our residents are training in? And then also, how do we really support programs and residencies that don't truly have much integration presently? How are we going to help move them along the spectrum so that residents really get a solid training in this domain and continue to advocate it going forward? So I'm going to just kind of pause there, kind of the overview of some of the changes that we're seeing. But I'd love to hear from this group a little bit more about, what is happening already in your programs and where you see your needs are going to be, because this is a place where STFM would really like to be supportive. Our mission is to make sure that we're providing good training for faculty and residents. And again, so how can we be helpful to support programs that may not have much integration going forward? So I'm going to pause there. I'm just kind of open for some questions. For folks who are on this call, how many of you are working in, I'm guessing a lot of you are here because you're already doing integrated care, but I'd love to hear what that looks like in your clinics and what you see the needs are.
I can jump in with some thoughts kind of to your first question. So I am behavioral science faculty for an FQHC. I'm actually in Idaho, so hope to see y'all soon. But I think something that I have been very aware of is that I think my family medicine physician colleagues, some of them don't actually understand what true integrated care looks like. And prior to this position, I worked actually at the VA in a pretty robust integrated care setting. And so I have found it has taken quite a bit of time to help folks envision what it could look like. And so I think my ask maybe of STFM would be to really kind of highlight the various levels and with like clear descriptions, because I do think my program tends to think, oh, India's around and can do warm handoffs like 2 half days a week. We are so integrated. And I'm like, I don't know if I agree with that. And so I think a larger organization clearly identifying the road that we could travel on to improve integration would be really valuable.
Absolutely.
All I would say is everything she just said also applies to me. All of those words are 100% true words. So yeah, I'm thrilled that this conversation is happening.
Mm-hmm.
I guess maybe another thought to your question, Linda, about supporting programs where maybe integration is less kind of prevalent as part of just the routine practice is like ways in which like STFM might be able to support like building kind of like regional like partnerships and collaboratives. I know that I think that's somewhere in the ACGME requirements just in general, but I think this would be a kind of like a great opportunity for doing that, whether it's through, didactic models like things like Project Echo or even any sort of, I think regional collaboration would be really helpful to get supported.
Yeah. All right, Joey, there is in the program requirements language about learning collaboratives. It's one of the things that is likely to be not mandated. Originally, it was going to be a requirement, but it doesn't look like that's going to stay in as a requirement, but rather an intent and a strong suggestion for programs to engage collaboratively. And I agree that this is a domain where we can really support each other and help each other learn from best practices. And how do you move from the lone behavioral scientist doing a few handoffs, a few afternoons a week to a fully integrated model. Yeah, good.
I think one of the things that I might add is at my location, we are co-located, and that's absolutely, I think, the limits of how I would describe it. We share a roof, but even I, as a faculty member in psychiatry and behavioral health here, I have a hard time getting patients in to see people in psychiatry and behavioral health. We are really just co-located. So maybe a part of it would include, just because you're in the same building doesn't mean it's provided integrated care, right? Mm-hmm. So it's got to include the warm handoffs. You've got to be in the room. You've got to be seeing the patients in real time. So some of my frustrations are coming through. Thank you for this conversation.
Yeah. I hear you, Bob. I worked previously in a different residency program where I was the only behavioral scientist, and I saw patients in clinic just 2 half days a week. It was more, yes, we shared an electronic record, but the degree of integration beyond that was very limited, and I was doing more traditional co-located therapy. And I think that's, again, a lot of programs may look at that as integration and yay, we're meeting the standard, and not really understanding how helpful we can be in a variety of different ways, that we can do those brief interventions after a warm handoff. that we can develop collaborative care models where we have care managers who are reaching out to the patients and then collaborating with the psychiatrist to inform a treatment plan so that we can have a broader reach to our patients who are not necessarily coming into clinic, but are those who definitely need mental health services and can't access them in other ways. And so really describing to faculty broadly that these are different models of integrated care, these are the advantages and disadvantages, and that you can have multiple models of integrated care within your same clinic, right? That if you want a stepped approach to integrated care, having that diversity of services may really help meet some of the mental health needs of our patient population.
Good afternoon, Adrian Sandoval. I'm a PharmD faculty here at UTRGV School of Medicine. We oversee in our department 3 different family medicine residency programs. So I've had the honor, pleasure, and experience of being in different types of integrated care. One of them is, the integrated where we have the ability to do co-precepting, co-visits. And I would say I second the advice on having some sort of formal structure and advice on how to take on integrating and developing integrated models. And I would start with simply looking at the co-located models. I would say the very first step would be to resist the urge to separate ourselves into precepting rooms. And this happens in another residency program where perhaps a behavioral health expert is in their own room seeing the patient individually and may only come out for certain times, versus in other programs, we're all precepting together and seeing the patients as needed together in real time. And so I think that physical divide is where initially it starts to do the co-located versus truly integrated model.
Yeah. That's such an important point. And we know that one of the things that helps integrated behavioral health work successfully in clinics is being very visible, right? If we're tucked away, people are going to forget we're there. But if we're in that same precepting room, if we're at where the nurses gather, we're visible, people are going to recognize, oh, yes, this is something that the behavioral health professional can help me with. Let me grab that person. And sometimes space issues can be a challenge in some clinics. So thinking about how to make that work within tight space, I know has been a challenge in our center at times.
I just want to chime in. So on the chat too, there was a contribution from Alex as well. And he was saying that he agrees with that and trying to encourage behavioral health education as it's happening through integrated practice, not as a segmented process, not having only the BH didactics and having everything kind of be completely and separated from the applied and integrated work and education side.
Go ahead.
So I'm at UTRGV as well with Dr. Sandoval and Dr. George. I was actually at the STFM Quality Improvement Conference last week. And so, kind of interesting seeing how different people are doing a lot of these different things as well. I guess one thing I was also thinking, and it reminds me of when I interviewed, before I was faculty, I was resident here, interviewed with Deepu a long time ago now. It seems like, I guess not that long. And he was talking about their integrated program, and I had been same thing at a co-location. I was like, oh, I know what that is, and then when I actually came here, I was like, this is completely different than what I expected. It was in a good way, but I almost wonder if that training on what integrated behavioral health is needs to start happening even at the medical student level. Because same thing, when people are interviewing and stuff like that, they don't actually even know what it is that the place that they're interviewing is doing, if they actually don't have an idea of what integrated behavioral health looks like. I don't know. I mean, I know STFM, a lot of the people I talk to are working with medical students, stuff like that as well. But I don't know if there's a way of implementing this more, even at the medical school level, so that way, by the time they're actually in their family medicine residency, there's at least a baseline. Because I think the majority of residents probably don't have a baseline, when they first enter into residency.
Mm-hmm. Absolutely. And I think about some of our new residents who are so eager to learn and so overwhelmed And it takes a while just to get, they think they have some sense of what a behavioral scientist does, but in many ways that's limited exposure. And so part of their big role is learning how we can be helpful to them, but also what can we teach them that they can manage, right? So that they've got some tools in their toolkit that they can go to if they're working with a patient with depression or sleep difficulties or anxiety, that they've got some things that they can start to implement right away with the patient while also involving the behavioral scientists. Because I don't think we want a system where they hear something like, oh, my patient's upset, let me just immediately grab the behavioral scientist, right? We want to make sure that our learners are also developing some skills so that they're more comfortable. And again, sort of, I think about that stepped care approach is when it goes beyond what the family medicine resident feels comfortable managing, that's when they can pull us in and be helpful. And I really do like that comment about integrating not just the clinical practice, but the educational realm, right? So that it's not, I used to have a behavioral health month during conferences. So everything was just regulated into this one particular month. And I said, this really doesn't work for me. This should be integrated into the full curriculum, not a behavioral health month, as somehow it's separated from the rest of the body. And so I had to advocate for making sure that it was integrated throughout the curriculum. How are you currently involving your residents in the integrated care? I'd love to hear about that.
I was going to add a comment on that, actually, so I'm glad you asked that question. So one of the things that we did in our program is really transition how we engage the residents in the curricular learning. So, we were really in the older, what I call like the generational differences in the behavioral science faculty role. I think in a lot of the older, at least in the way that I was initially exposed to it, and it would really focus a lot on rotation, reflections, reading, kind of helping them be more aware. And then as I started transitioning to like really listening to our residents, we actually sat down, I think Dr. Fahey's class, one end of the year, and we really asked them to give us some honest feedback on what's working and what's not working. And the big split that we noticed in our rotations was they don't do with us what they do in a cardiology rotation or another rotation, which is essentially gain the basic skills of doing assessment and gathering history that is focused and figuring out ways to intervene at that moment. So what we've done is we've shifted our curriculum to include a lot more clinical teaching and less didactic teaching. Our didactics are twice a month, which is embedded into the normal didactic routine of the residency. But the clinical teaching basically involves the resident either following me or one of the other behavioral health consultants in clinic, and then they shadow us for 10 to 12 visits, and they start scribing by the second or third visit just to get them used to the consultation format. We have very structured readings that we assign to them that includes chapter 3 of the Hunter Goody book, which is the integrated behavioral health in primary care step-by-step approach. And that kind of exposes them to like basic behavioral interventions that can be done in primary care. And by the time they finish their first year rotation, which is about a month with us, they probably would have had over 16 clinic half days where and half of that they're leading the consultation. And then in the second and third year, we have a 2x2 model in the clinic where we have embedded a half day into their 2-week ambulatory block where they are functioning in clinic as a behavioral health consultant. And they're precepting with Joanna, who's our other behavioral health consultant, or myself if I'm there. And we're basically running it like a normal clinic. And I think that's a perception and an experience shift that is necessary to say and show that these things can happen in a routine primary care appointment.
That is phenomenal. I am so impressed with the degree to which you've really brought your residents into acting in the role of the behavioral scientist, behavioral health care manager. I think that is exactly kind of a direction we need to go. But just, that's phenomenal. Just kudos. We're not that far yet. I have residents who work with what we call our population health staff, but there are behavioral science professionals, but not nearly to the extent that you've been able to develop that. I'm really impressed.
Linda, just to jump in for a second here on the chat, a point that was brought up was, I guess, getting some more, generating more support for these family medicine training programs, residency training programs, kind of using these new program requirements for like advocacy purposes. So maybe to expand the behavioral health workforce in a particular family medicine practice or another type of clinic. Really trying to make it where it's not just on the single behavioral scientist to do all of this. It's like, here are the requirements. This is kind of the standard. How can we make this a clinic-wide effort and expand everybody's reach to this as well?
I do think the new standards help us in that way. And the impact statements published by ACGME really recognize that some programs might be required to or might need to hire behavioral health professionals. I wish they had gone beyond just saying they have to have an experience in integrated care. Because again, I think some programs may look at that and say, okay, well, we may not even really have a behavioral scientist on faculties. So if we bring in, a social worker for a half-day week, boom, we've met the requirement. And I don't think that's the intent behind the requirements in any way. But they didn't really specify the degree of integration or how expansive it is within the resident's experience. That being said, I think one of the big challenges has been to bring in enough behavioral health professionals in order to do true integrated care. Because if you're a lone behavioral scientist, you're really not going to be able to provide the consistency of availability that is necessary to have a fully functioning integrated care. Because we know if it's only offered a couple days a week, residents aren't getting the exposure, other faculty aren't getting the exposure, they're not seeing how critical this is and helpful it is for them and their patients consistently. So we really need to have availability of the behavioral health professionals on a consistent basis when our clinics are running. That being said, we also know that it can be challenging to have the fiscal support for behavioral health professionals. And I know a lot of times getting things started, at least in my system, has been focused on grants. So if I can get a grant to help get the ball rolling, then people start to see the value in having integrated behavioral health professionals, and then the system starts to support it. And that's kind of what happened in our system. It started with some grants, and then our clinic leaders started to say, I can't live without this. This is necessary. We need this team here to help support the work that we're doing. And that went from our clinic in family medicine to other family medicine clinics, and now into peds and GI and in internal medicine are all now really getting support with integrated behavioral health. And they're doing it mostly through behavioral health collaborative care management models. So different kinds of models that might work, but I know that that can be a real challenge. If you can get program leadership to talk to other programs where it's been very successful, I think that that also helps. And I think that's, again, where CFHA is so powerful, because I know you've got a lot of members and leaders who are evaluating this work and are able to say, here are the benefits. We may not necessarily pay for ourselves in billing, which is, a whole nother issue, but cost savings in other ways, really improving the quality outcomes for our patients, improving provider satisfaction for our colleagues are really critical things. I also see that they're needing to train more mental health professionals in integrated care. Absolutely. That is a really important piece of it. Thinking about how can we have students from social work, from psychology, train with us in these integrated care models. So, because it is a very different way of practicing. And a lot of psychologists, I can speak from that realm, are not trained in integrated care initially. And the idea of, what do you mean I don't do a full assessment? You just want me to go in the room and do something? That seems very, very foreign. And so I was telling Corey, just throwing it out there, at UNC, we are expanding our integrated training for social workers and psychologists. We're just about to start a new internship track for psychologists, specifically in integrated care. So that's one new resource that's coming there to help train that workforce. Good. All right. I'm looking at some of the other chats that are coming in. So another area, STFM can provide advocacy and helping those systems and programs understand the cost savings and return on investment. Absolutely. And how, being able to demonstrate that to clinic and administrative leadership is really important. Being able to do that. Kind of paid support. Yeah. So the cost issues again, even when thinking about training social workers, those kinds of things. Yeah. How have people been successful in advocating and making that argument that we need to expand behavioral health staff? Have folks on this call been successful with that?
I'll just say that the buy-in kind of takes a while, but as long as you're kind of continuously advocating for it and like really listening to feedback from learners and other colleagues really helps. And I think for us, it was really knowing that what we were doing traditionally wasn't really hitting what it needed to hit, helped us kind of forcefully redesign. And I also want to give a shout out to the UT Health Science Center in San Antonio, Dr. Stacy Obeid, and then the CHCW in Washington. They are also kind of a very similar way of training residents, which is really focused on reducing the gap between, just focusing on education on the clinical side much more often. If you can kind of make that the prime directive of training behavioral health skills for doctors, I think it makes a big difference.
So I was going to add something too. I don't know that I totally heard your question, but I think you were talking about justifying adding in more behavioral health staff. And so it was sort of for us, so we have myself, I'm a faculty member, and I probably do like you 2 half days of precept day plus do have a more traditional caseload, a half a day a week. But we also have a full-time licensed professional counselor and then 2 psychology graduate students, doctoral students so between the 4 of us, we make sure there's always someone in the precepting room. And when we're not in the precepting room, we are seeing scheduled, more traditional therapy kinds of patients. But that allows us to spend time in the precepting room because we did a whole business model, and we do cover not my salary because I'm so few in there for such a little amount of time, but the licensed professional counselor, we are able to generate enough revenue from a fee-for-service basis to cover it.
I think, Lori, what you're talking about, involving graduate students is a good way sometimes. It's an affordable way to start to introduce. And it was when I came to UNC, that was one of the first things I did was connect with the Department of Psychology and say, I'd like to start to offer practicum. And again, it allowed us to have more exposure to more of the other clinicians who saw that it's so valuable. And that's when we started to get more and more buy-in.
Right. And the more you're available, the more they want you. So we were underutilized when we were in the precepting room part-time. Now that we're there full-time, we're constantly calling for backup.
Mm-hmm.
Yeah.
Good. For those of you who, again, are kind of responsible for the behavioral health curriculum in your residency programs, I'm curious about what kinds of revisions you're anticipating making to your curriculum with some of the new ACGME standards. And if there's some things that STFM can do to support you in that. Focus on clinical teaching, what that looks like. Okay. Can you say a little bit more about that?
All right, so I think a few things that we think about is just really adopting the preceptor model that our physician colleagues use to do the regular, that's how we train. And so learning to really adopt that as part of behavioral health expectations as well, and not having a whole separate process, which is like removing anything that we do with the mind-body split, even in just everyday interactions and conversations. And then, when residents handle their own patients for consults, they're responsible for the note and we sign off on them. So we've kind of picked up a lot of things on the fly, but if STFM can do a little bit more formalized training for behavioral health folks on moving away from psychotherapy supervision kind of frameworks to adapting to a very primary care, family medicine, culture-oriented way of orienting those skills training, I think that would be helpful. And that includes things like the 1-minute preceptor model and other things related to feedback, but all focused on a family medicine kind of framework, rather than the traditional mental health frameworks of learning and acquisition of skills.
Yeah. One of the things that was really talked about with the new family medicine standards is that the practice is the curriculum, right? And so really recognizing, the more that we can integrate ourselves in the traditional practice itself and build our teaching in that way, that we're likely to be more successful. And my guess is that Bob, as the new director of STFM's Behavioral Science Family System Educator Fellowship, is taking notes on that as well and thinking about how to integrate some of those things into the curriculum for the behavioral science fellows.
So absolutely, I would also encourage anybody who might be interested in that, an early career person, someone within first 5 years of having a role as a behavioral medicine faculty member in a residency, FM residency program, to consider applying for it. The application is up now. It's on the STFM website.
So if you know of any folks within CFHA who are new faculty teaching in family medicine residents, the fellowship is a tremendous resource and can really help people start to develop their identity as a behavioral science educator, and helps you learn the nuances of some of those things, like what does it mean to precept? What is the 1-minute preceptor? How can we help our message be received by our learners in the most effective way. And those are some of the things that you learn.
Working with challenging residents. We haven't fleshed out the curriculum yet for the upcoming cohort, but I can almost guarantee you that the topic of this discussion today will consume a fair amount of our fellowship curriculum.
Terrific. How many folks, I'm just curious, one of the models of integrated care that we haven't talked about is reverse co-location or reverse integrated care, where you have primary care within a mental health setting. And I'm curious if folks have that opportunity for training for family medicine residents. People shaking their heads kind of no. Yeah. So I think that's another thing for us to think about as a community is, again, expanding beyond maybe our clinic walls and thinking about how do we train residents in that model as well. Because going forward, again, sometimes we get locked into thinking about our family medicine clinics and saying, you know what, family medicine actually also has a really important role to play within mental health organizations as well. And thinking about that. Okay. Marjorie, do you want to just talk a little bit about what you do there, and are you involving residents in that at this point?
So earlier she had mentioned her camera and microphone are not working.
Thank you, Corey. All right. Marjorie just noted that she works in a setting like that, where it's a mental health clinic that provides primary care as well. And again, I think that that's another potential opportunity for us to think about having residents at least go experience that and maybe spend some time shadowing in those kinds of models as well, because it may be something they get really jazzed about and energized about, particularly if we've got residents who have a strong interest in behavioral health, that could be an important thing. Working in both models, working towards having family medicine residents rotate in that clinic. Yeah. We also have that model at UNC, and we partner with a mental health crisis center, Wakebrook. And so our residents do spend time there with family medicine faculty, providing that reverse co-location or reverse integrated care. It tends to be more co-location than truly integrated, but at least they're seeing that there's a role there for family medicine physicians or primary care physicians, again, that can help meet the needs of our patients in a different way. Okay. So other questions or thoughts that people had about the new program requirements and how it may impact us as a community. I do think that this is a place that we will be able to collaborate. And I know that STFM is starting some task forces to really study this a little bit more, to think about what our members' needs are going to be, and how we help people move towards not just checking the box that we have integrated care, but truly making sure that residents are training in robust integrated care settings. So good. All right. Oops, I'm seeing some other comments pop up. Guidance on measuring outcomes of behavioral health education. Well, that's a really good question. All right. How do we measure the impact of what we're doing? How do we go beyond just, how did they perform on the ITE psychology section? Yeah, I know that's something that I've struggled with as an educator, is how do I really demonstrate that residents are taking what I'm doing and really applying it with their patients and those kinds of things. Direct observation is one way that I tend to assess that. So I can see by watching the residents what they're doing in the room with their patients, and are they applying some of the skills that we've taught in terms of brief interventions? How well do they do in doing a handoff to a behavioral health specialist then too. I'd kind of include that in my direct observation if I can, and watch for that and give coaching related to that. But I think that's a domain that we have more work to do. What do we look at in terms of changes in attitudes about working with patients with mental health conditions, for example? That's something I've started to explore a bit, and not found much change, I must admit, sadly. So, okay.
Well, and as you're talking, it kind of makes me think that, like, you know, I think a lot of us pick up all of these examples of kind of different ways to teach and different ways to kind of give some of these experiences from like conferences and informal collaborations. But it would be nice to have, you know, some standing centralized resource for different examples of like kind of ways to go about doing more of like the clinical teaching, like that Dr. George was talking about, or best practices around, you know, measuring outcomes, doing those observations. You know, I could imagine almost like a bit of like a menu of different things that you could try to adapt to your particular setting. So something that would be really cool to have, especially for maybe like newer programs where they're really having to do more like work to get this integration going.
Right. Good. I know, you know, STFM has a couple of resources, some more broadly just educational in general for faculty through the faculty development resources. Within the behavioral science community, there's also a depository of resources that have been reviewed for sort of teaching topics that are helpful and teaching strategies. But I don't know that we do a really good job of promoting that and letting people know that those resources are out there. What about through CFHA? What kinds of resources, or do you have something similar to what you're talking about, Joey, within CFHA? My folks who have to transition already to the next thing, yeah.
I'm not sure. I mean, I'm probably not the best person to answer that. But you know, I know like the various like special interest groups have, you know, various resources that are on their individual pages. And then, you know, there's a lot of like on-demand material from like past, like the couple past conferences and whatnot, but I'm not sure about kind of how well that fits what you're talking about.
So, definitely. Oh, excellent. Well, I do think this is an opportunity for us to continue to collaborate. And again, we're going to see more demand for integrated behavioral health within our residency programs. We're going to be seeing more demand for behavioral science faculty as well. And how do we train that workforce up to be ready to meet those needs? It's going to be an ongoing issue. So thank you, everyone, for joining in to this discussion this afternoon. And it was nice to meet some new folks and see some old friends as well.